Good morning, everyone. My name is David Patrician, a PGY3 resident from the University of Saskatchewan. Today, I thought it'd be useful to review the bipolar and related disorders chapter of DSM-5-TR with some supplemental information provided from Kaplan and Staddock's Comprehensive Psychiatry textbook and the CANMAT guidelines for bipolar disorder. These are the objectives for today's presentation. I hope you can walk away from this presentation with an understanding of the core features of each of the disorders in this chapter, their epidemiology and risk factors, differential diagnosis, and with some idea of what their treatment might look like. I hope to stimulate conversation by running through a number of clinical cases. So without any further ado, let's begin.
Alright, case 1. So you were a PGY1 resident participating in an elective at Student Wellness Center where you've been asked to see Manny, a 24-year-old male, for assessment of insomnia. Manny reports a decreased need for sleep for the past 4 days, associated with distractibility and talkativeness. Regarding emotions, Manny tells you, "I'm very happy. Maybe it's because I've been so productive lately." He denies substance use aside from a drink once in a while and the odd joint when it gets passed around at a party. Medical history is non-contributory, and he was adopted. He was treated for a major depressive episode 1 year ago, during which he nearly dropped out of school and failed 2 classes. This was treated with CBT, which was efficacious. Keeping in mind this is a presentation on bipolar and related disorders, what is the most likely diagnosis in this case? So this is bipolar 2 disorder. Bipolar 2 is defined by a pattern of recurrent mood episodes consisting of 1 or more major depressive episodes and at least 1 hypomanic episode. I've listed the abbreviated DSM-5-TR criteria here. A common misconception regarding the diagnosis of bipolar 2 disorder is that there is no functional impairment, and in fact, some improved function during hypomania. Whilst this may be true during periods of elevated mood and increased goal-directed activity, those with bipolar 2 disorder spend most of their time depressed. Furthermore, transitions between mood episodes can lead to functional impairment through inconsistent performance in occupation or school leading to distress. Now, there are a number of specifiers that apply to a diagnosis of bipolar 2 disorder. These pertain to the most recent episode, remission status, and severity. As seen in my depressive disorders presentation, there are a number of other core specifiers that may apply. These include anxious distress, atypical features, catatonia, peripartum onset, mixed features, melancholic features, mood congruent psychotic features, mood incongruent psychotic features, and seasonal pattern. Please note the absence of rapid cycling, which is the only exception to the bipolar 1 disorder specifiers, which we'll talk about later. Before we move on, can somebody tell me what is a hypomanic episode? These are the criteria for a hypomanic episode. Criteria A, abnormally and persistently elevated expansive or irritable mood and persistently increased goal-directed activity or energy lasting 4 days and present most days most of the time over that time period, or any duration of hospitalization is necessary. There are 2 main mnemonics considered in mania and hypomanic episodes. These are dig fast and GST paid. 3 of these symptoms are required if mood is elevated or expansive, and 4 of these symptoms are required if mood is irritable. During a hypomanic episode, function need not be impaired, and the mood and functional change must be observable by others. It cannot be due to a substance, a medication, or another medical condition. So again, here are those 2 mnemonics, and here they are spelled out. So dig fast stands for distractibility, indiscretion, grandiosity, flight of ideas, activity increase, sleep decrease need, and talkativeness. For GST pay, these are grandiosity, sleep decreased need, talkativeness, pressured speech, activity increased, indiscretion, and distractibility. Now back to our case. You review Manny with your supervisor, Dr. H, at the Student Wellness Center and present your preferred diagnosis of bipolar 2 disorder. Dr. H agrees with your diagnosis and poses the following questions. What is the 12-month prevalence of bipolar 2 disorder? What is the mean age of onset of bipolar 2 disorder? And what are the biopsychosocial risk factors for bipolar 2 disorder? For epidemiology, the 12-month prevalence of bipolar 2 disorder, according to the DSM-5-TR, is 0.8%, and the mean age of onset is in the mid-20s. Risk factors include family history of bipolar 2, bipolar 1, or major depressive disorder. Up to 1/3 of individuals with bipolar 2 disorder have family history of some kind of bipolar disorder. However, the genetic component is thought to differ from that of bipolar disorder type 1 and schizophrenia. Poor prognostic factors include rapid cycling, whereas good prognostic factors include younger age of onset, less depression, higher level of education, fewer years of illness, and marital status, that is, being married. Dr. H is satisfied with your knowledge of the diagnostic criteria and epidemiology of bipolar 2 disorder and asks you to present your differential diagnosis and to include at least 4 alternative diagnoses, as well as reasons why they don't fit the current clinical picture. In responding to Dr. H, what is the differential diagnosis for bipolar 2 disorder? This is the differential diagnosis for bipolar 2 disorder according to DSM-5-TR. Let's take each of these in turn. How does bipolar 2 differ from major depressive disorder? Well, in major depressive disorder, there is no history of manic or hypomanic episodes, purely major depressive episodes. What about cyclothymic disorder? Well, in cyclothymic disorder, there are numerous periods of subsyndromal hypomanic and depressive symptoms. However, no episode is ever met. That is, there are no major depressive episodes, hypomanic episodes, or manic episodes at any time during the disorder. Now, there was a time when bipolar disorder and schizophrenia were thought to be at various points along the same spectrum. In modern-day psychiatry, how do we tell them apart? Well, in schizophrenia, there are no major depressive episodes occurring with active phase symptoms. Major depressive episodes may exist for a minority of the time, and in that case, schizophrenia would still be diagnosed. In bipolar 2 disorder, we may have major depressive episodes with psychotic features, but these symptoms would co-occur. Okay, now what about schizoaffective disorder? You get all kinds of mood episodes in schizoaffective disorder. Schizoaffective disorder is characterized by periods in which depressive symptoms are concurrent with the active phase symptoms of schizophrenia, and periods in which delusions or hallucinations occur for at least 2 weeks in the absence of a major depressive episode. The diagnosis is bipolar 2 disorder with psychotic features, if the psychotic symptoms occurred exclusively during the major depressive episodes. Sometimes medical conditions underlie our patients presenting with bipolar-like illnesses on CL. What helps us separate them? Well, in these cases, there is a medical condition which results in symptoms reminiscent of bipolar disorder. The diagnosis of bipolar and related disorder due to another medical condition should be made instead of bipolar 2 disorder if the hypomanic episodes are judged, based on history, laboratory findings, or physical exam, to be the direct physiological consequence of another medical condition, for example, Cushing's disease or multiple sclerosis. And what about medications, substances, or toxins induced to bipolar disorders? Similar to bipolar and related disorder due to another medical condition, there must be the presence of a substance or medication that can cause those bipolar symptoms. It's super common to see bipolar 2 and ADHD together in a student health clinic. What helps us tease them apart? So the key differentiating feature between ADHD and bipolar 2 disorder is that the symptoms in ADHD are not episodic. However, they are episodic in bipolar 2 disorder. What about personality disorder? Well, the same convention as applies for ADHD also applies when evaluating an individual for a personality disorder, such as borderline personality disorder, because mood lability and impulsivity are common in both personality disorders and bipolar 2 disorder. Symptoms must represent a distinct episode, and the noticeable increase over baseline required for the diagnosis of bipolar 2 disorder must be present. A diagnosis of a personality disorder should not be made during an untreated mood episode unless the lifetime history supports the presence of a personality disorder. How about bipolar 1 disorder and the rest of the disorders in this chapter? Well, the presence of a hypomanic episode instead of a manic episode separates it from bipolar 1 disorder. If there were not enough features to fully diagnose, and we didn't have enough time, we could use something like unspecified. If there was enough time but not enough symptoms, we could use other specified, i.e., we would have to consider whether or not there was a presence of a fully syndromal hypomanic episode and major depressive episode. You return to Manny and present your management plan. With safety in mind, how would you approach management in the case of bipolar II disorder, in general? Manny is presenting with a hypomanic episode and seems to be functioning well. Would you treat him? Some patients have no to minimal functional impairment in bipolar II disorder and may even experience brief periods of above normal functioning in the context of hypomanic episodes. However, prolonged, relatively severe, or mixed or irritable hypomanic episodes may be impairing. In terms of management, it would be important to discontinue agents that can worsen or prolong symptoms, that is, antidepressants, and to initiate appropriate pharmacotherapy. However, there's not much evidence for doing this during a hypomanic episode. Several weeks later, Manny returns to the Student Wellness Center for follow-up. You were surprised to find him despondent and dysthymic. He reports that for the past 2 weeks, his mood has been hopeless and he is no longer capable of deriving pleasure from his hobbies and recreational activities. Additionally, Manny has been eating poorly, experiencing hopelessness, and reports poor concentration as well as passive suicidal ideation. What's going on here? With safety in mind, how would you approach management for bipolar II disorder in this case, generally speaking? So let's dig into the pharmacology a little bit. For acute management of bipolar II depression, we'd have one first-line option, and that's quetiapine. For maintenance, we have 3 options: quetiapine, lithium, and lamotrigine. Second-line options for acute management of bipolar II depression include lithium, ECT, venlafaxine, lamotrigine, and sertraline, whereas second-line options for maintenance include venlafaxine. Third-line options for acute management of bipolar II depression include VPA, agomelatine as an adjunct, and bupropion as an adjunct. Third-line options for maintenance of bipolar II depression include carbamazepine, antidepressants, others, VPA, escitalopram, risperidone, and fluoxetine. Risperidone has the lowest level of evidence for support as a third-line option. Now on to case 2. You are a family physician, and today Mary has asked to see you regarding a private health matter. Upon entering the consultation room, you were surprised to find that Mary is not alone. Beside her is her husband Mike, known to you since their wedding in June 1 year ago. From her appearance, you can tell that Mary has been crying and is deeply frustrated. Before you can even introduce yourself, Mike begins speaking rapidly and puts his hand out to shake yours, gripping it tightly. From the bags around his eyes, it appears that Mike has not been sleeping well, despite his apparent energy. As you take your seat and engage Mary in history-taking, Mike becomes increasingly irritable at Mary's shushing, and eventually begins to yell. Mike stands and begins posturing. Your attempts to calm him fail, and office security quickly attend the consultation room. Eventually, police arrive, and Mike is taken to the hospital for assessment. Mary is quite upset by the whole ordeal and provides you with the following additional history. I'm so sorry, Doc. This is the only way I could get him to see a doctor. Mike's been like this for the past 10 days, and it's only getting worse. I didn't know that he would become violent. He's not been sleeping, and he's been going out at night, which is unusual for him. The other night I smelled different perfume on his clothes. He's always been faithful. I think he's lost his mind. This morning he was telling me that he's the son of the King of Mars. I don't get it. Keeping in mind this is a presentation on bipolar and related disorders, what do you think is the most likely diagnosis? And as a bonus point, does anybody know what specifier could be applied in this case? This is bipolar I disorder, the essential feature of which is presence of at least one manic episode, which is a distinct period of abnormally, persistently elevated or expansive, or irritable mood and persistently increased goal-directed activity or energy that is present most days, most of the time, for at least 1 week, or any duration if hospitalization is required. Abbreviated criteria include a history of a manic episode, which is a hypomanic episode with dysfunction, hospitalization, or psychotic features that's not consistent with schizophrenia and not the result of a substance, medication, toxin, or general medical condition. Specifiers pertain to the most recent episode, remission status, and severity, as well as the same specifiers mentioned earlier, which pertain to bipolar II disorder. However, as you will see, I've highlighted rapid cycling, which is available for use in this disorder, but not in bipolar II. Oof, what a day. The clock reads 1600 and it's time to pack up and head home for a well-deserved rest following a challenging day at the office. On the way home, you find yourself thinking about Mike's case. That is the most interesting patient you saw today. And you ask yourself the following questions. What is the 12-month prevalence of bipolar I disorder? What is the mean age of onset of bipolar I disorder? And what are the biopsychosocial risk factors for bipolar I disorder? Regarding epidemiology of bipolar I, 12-month prevalence is 1.5%, lifetime prevalence is roughly equivalent between males and females, with a mean age of onset of 22, and a peak in onset between the ages of 20 and 30. Biological risk factors include its high heritability, and in first-degree relatives there's a 5 to 10% of developing the disorder. In terms of temperament, hyperthymic, depressive, cyclothymic, anxious, and irritable temperaments are all correlated with bipolar I. Sleep and circadian disturbances are also noted, as well as reward sensitivity and heightened creativity. Adverse childhood events are associated with bipolar I disorder, as are recent life stress and other negative life events. In terms of depressive episodes, goal attainment, life events associated with manic episodes, and cannabis use associated with first onset of manic episodes, which is an important risk factor to remember. Content with your current level of knowledge regarding the epidemiology of bipolar I disorder, considering how interesting your life might have been if only you'd gone into psychiatry instead of family medicine, you decide to really challenge yourself and pose the following question. What is the differential diagnosis for bipolar I disorder? So what is the differential diagnosis for bipolar I disorder? This is the differential diagnosis for bipolar I disorder. As you can see, it's not entirely different from that of bipolar II. Okay, what about MDD? Once again, there's no history of manic episodes, only depressive episodes. What about other bipolar disorders? Well, in differentiating bipolar II from bipolar I, once again we consider the presence or absence of a hypomanic or manic episode. In cyclothymia, we have subsyndromal mood episodes. In unspecified and other specified, we have vague symptoms reminiscent of a bipolar disorder without our ability to confirm these, or without enough symptoms to make that full diagnosis. What about anxiety disorders? Careful history of symptoms is needed to differentiate generalized anxiety disorder from bipolar disorder, as anxious ruminations may be mistaken for racing thoughts and vice versa, and efforts to minimize anxious feelings may be taken as impulsive behavior. Similarly, symptoms of post-traumatic stress disorder need to be differentiated from bipolar disorder. It's helpful to assess the episodic nature of these symptoms as described in classic bipolar I disorder, as well as to consider symptom triggers in making this differential diagnosis. How does bipolar I differ from bipolar disorders due to another medical condition? Once again, we have to have the presence of a general medical condition that can cause those symptoms. What about meds, drugs, and toxins? Well, like due to another medical condition, we have to have a substance or medication present that can cause these symptoms. Like I said, schizoaffective disorder gets mood symptoms too. How can we distinguish bipolar I from schizoaffective disorder? Well, schizoaffective disorder is characterized by periods in which manic and major depressive episodes are concurrent with active phase symptoms of schizophrenia, and periods in which delusions or hallucinations occur for at least 2 weeks in the absence of a manic or major depressive episode. The diagnosis is bipolar I disorder with psychotic features if the psychotic symptoms have occurred exclusively during manic and major depressive episodes. And ADHD. I'm sure you guys remember this one. So in ADHD, we have persistent symptoms with onset under the age of 12 versus the episodic and usually older onset of bipolar disorder. Now this one's a bit different. Many student resources ask about early onset bipolar disorder in the child and adolescent population, and they'd like to have you distinguish it from DMDD. So let's see how we differentiate the two. In individuals with severe irritability, particularly children and adolescents, care must be taken to apply the diagnosis of bipolar I disorder only to those that have had a clear episode of mania. That is, a distinct time period, the required duration during which the irritability was clearly different from the individual's baseline and was accompanied by the onset of the other characteristic symptoms of mania, such as grandiosity, decreased need for sleep, pressured speech, involvement in activities with a high potential for painful consequences, etc. When a child's irritability is persistent and particularly severe, a diagnosis of disruptive mood dysregulation disorder will be more appropriate. Indeed, when any child is being assessed for mania, it is essential that the symptoms represent a clear change from the child's typical behavior. And lastly, personality disorders. Personality disorders such as borderline PD may have substantial symptomatic overlap with bipolar 1 disorder, since mood lability and impulsivity are common in both conditions. In order to make a diagnosis of bipolar 1 disorder, symptoms of mood lability and impulsivity must represent a distinct episode of illness, or there must be a noticeable increase in these symptoms over the individual's baseline in order to justify an additional diagnosis of bipolar 1. Ha, that was easy, you snort. No sooner do you do so than your mind flashes back to medical school, where, during clerkship, you met Dr. Patrician, a psychiatry resident obsessed with mnemonics and memorizing guidelines for mental disorders. What were those weird words he used to recall common medications used in bipolar disorder? With safety in mind, how would you approach the treatment in the case of bipolar 1 disorder in general? More specifically, how would you treat acute agitation, mania, depression, and maintenance? What about psychotherapy? So it's easy. For acute agitation, we have ALLO-Rs. For mania, we have LQ-VAP-RC and CARA+. For depression, we have QL3 and versus BCOF. And then for maintenance, we have ALQ-VAL and ORC-PLEASE. These mnemonics stand for various treatments used in each phase of management in bipolar 1 disorder. For agitation, we have first-line agents remembered with ALLO, which stands for aripiprazole, lorazepam, loxapine, and olanzapine. And we have second-line agents which are remembered with the mnemonic Rs, asenapine, haloperidol, risperidone, and ziprasidone. What about for mania? Well, we have first-line agents, monotherapy, LQ-VAP-RC, which stands for lithium, quetiapine, VPA, asenapine, paliperidone, greater than 6 milligrams, risperidone, and cariprazine. And then for first-line combos, we have CARA+, which stands for quetiapine, aripiprazole, risperidone, and asenapine, all of which would be paired with either lithium or VPA. Then what about for depression? First-line options are QL3, so here we have quetiapine, lithium, lorazepam, lamotrigine. And recall that lorazepam can be an individual agent or paired with lithium or valproic acid. Lamotrigine can be on its own or as an adjunctive medication for treatment. Our second line options for treatment of bipolar 1 disorder depression include VPA, SSRIs, bupropion. These are as an adjunct, ECT, cariprazine, and combination olanzapine fluoxetine, which we don't have in Canada. This is remembered with versus BCOF. And for our first line options for maintenance of bipolar 1 disorder, we have ALQ-VAL, which stands for asenapine, lithium, quetiapine, VPA, aripiprazole, and lamotrigine. It's important to note that quetiapine can be paired with either lithium or VPA. Aripiprazole can be oral, IM, or paired with lithium or VPA. And then for our second line options, we have ORC-PLEASE, which stands for olanzapine, risperidone LAI, carbamazepine, paliperidone greater than 6 milligrams, lorazepam plus minus lithium or valproic acid, and ziprasidone plus minus lithium or valproic acid. You guys can come back to this slide later. We all know that drugs only work when you take them, and even then not all the time. These are the features associated with partial and non-adherence, represented in a table. Now what about psychotherapy? What psychotherapies are indicated in bipolar 1 depression? What about bipolar 1 maintenance? So as we can see, the first four options are the same. In maintenance, we have an additional fifth option, which is peer support. So these are psychoeducation, cognitive behavioral therapy, family-focused therapy, and interpersonal and social rhythm therapy. Now on to case 3. Ron, a 19-year-old male, presents to the mood disorders clinic with a history of long-standing mood problems. He describes always being moody, and you learn that as a child he struggled with months of feeling irritable, which led to difficulties around home and school. More recently, he has been struggling with fluctuating mood that never quite met criteria for a major mood episode, with little reprieve. There's no history of psychosis, and there's never been a period of more than 2 months where symptoms have not been present. What is the most likely diagnosis in this case? Now, this is cyclothymic disorder, the essential feature of which is chronic fluctuating mood disturbances involving numerous periods of hypomanic symptoms and periods of depressive symptoms that are distinct from each other. In abbreviating the DSM-5-TR criteria, in order to receive a diagnosis of cyclothymic disorder, the disturbance must have been ongoing for at least 2 years in adults or 1 year in kids, and be punctuated by numerous periods of manic or major depressive symptoms. Manic or major depressive periods are present at least 50% of the time, and the individual is never symptom-free for more than 2 months. They cannot have ever had a major depressive episode, hypomanic episode, or a manic episode. They cannot have a schizophrenia spectrum or other psychotic disorder. It cannot be due to a substance, medication, or a general medical condition, and it must result in dysfunction. There is one specifier we can apply to cyclothymic disorder, and this is with anxious distress. Who can tell me the criteria for anxious distress, and who knows why it's important to consider anxiety in a mood disorder? Once again, here I've highlighted the specifiers which can be applied to bipolar 1 and bipolar 2, and I've crossed them all out except for anxious distress. Ron accepts your preferred diagnosis of cyclothymic disorder with some ambivalence, but is just curious enough to pose the following question regarding the epidemiology of this disorder. What is the lifetime prevalence of cyclothymic disorder? And what are the risk factors for developing cyclothymic disorder? In terms of epidemiology, lifetime prevalence is 0.4 to 2.5%. Obviously, this varies widely. Prevalence in mood disorders clinic is between 3 to 5%, and it's equivalent between males and females in the general population. However, in clinical samples, females are more likely to present. And for risk factors, the DSM-5-TR notes that first-degree relatives are more likely to have major depressive disorder, bipolar disorder type 1, bipolar disorder type 2, and they also note an increased familial risk of substance and related disorders. It's more common in first-degree relatives of individuals with bipolar 1 disorder than in the general population. Well, it does make me feel a bit better to know that this isn't bipolar disorder, but maybe my mom having that condition has led me to having cyclothymia, or whatever you called it. Could it be anything else? How sure are you that it's not bipolar disorder? Well, you guys know the drill by now. What would you include on your differential diagnosis for cyclothymic disorder? Here's the DSM-5-TR differential diagnosis of cyclothymic disorder. Here we go again. So bipolar disorder due to another medical condition versus cyclothymic disorder. Once again, there must be a general medical condition that can cause symptoms of mood disturbance. And substance and medication-induced bipolar-related disorder, as well as substance and medication-induced depressive disorder. Well, no surprises here. Once again, we need the presence of a substance or medication that can cause these symptoms. What about bipolar 1 or 2 with rapid cycling? That's actually a pretty good question, but an easy one if you recall the criteria. Both disorders may resemble cyclothymic disorder by virtue of the frequent marked shifts in mood. By definition, in cyclothymic disorder, the criteria for a major depressive, manic, or hypomanic episode have never been met, whereas a bipolar 1 disorder and bipolar 2 disorder, specifier with rapid cycling, requires that full mood episodes be present, at least 4 out of 12 months. And what about borderline? So, borderline personality is associated with recurrent, brief, marked shifts in mood that may suggest cyclothymic disorder. Engagement in potentially self-damaging behaviors can be seen in both conditions, but would need to occur in the context of other hypomanic symptoms to be related to cyclothymia. Mood instability in borderline PD occurs in the domains of anxiety, irritability, and sadness, whereas elation, euphoria, and or increased energy are not characteristic features of borderline personality disorder. If the criteria are met for both disorders, both borderline personality disorder and cyclothymic disorder may be diagnosed, not mutually exclusive. Okay, I guess you know what you're talking about, and it makes sense when you phrase it that way. So what are we going to do about it? Safety in mind, how would you approach treatment in the case of cyclothymic disorder in general? Now, whilst research is sparse regarding treatment of cyclothymic disorder, I think it can be best understood by looking at the component parts of this disorder. Essentially, you have mood disorder elements, some personality flair to it, and some impulse control problems. In fact, sometimes it's understood as an extreme version of cyclothymic temperament, which means we might want to treat it more like a PD. And just to flesh that out, cyclothymic temperament is a more or less permanent instability of mood, thinking, and activity, which is frequent in bipolar disorders. So there's a bit of crossover there, which makes it a little more confusing. There's some evidence for psychoeducation, CBT, and well-being therapy, although I'm not sure what well-being therapy really is. In terms of psychopharmacology, one article suggested lithium, valproic acid, lamotrigine, quetiapine, olanzapine, TCAs, which I thought was odd, and SSRIs. Non-pharmacological agents studied in this disorder include omega-3 and choline. And in terms of lifestyle recommendations, establishing routines, avoiding alcohol and stimulants, and encouraging good coping all have some evidence. Now on to case 4. You are a fourth-year psychiatry resident rotating through your consultant liaison block at the University Hospital, and you've just been asked to see a 48-year-old woman for the chief concern of mania. Jane was admitted 4 days ago for a multiple sclerosis flare and prescribed high-dose steroids. On exam, she is distractible, without fluctuation throughout day and night, grandiose, she believes God has a special purpose for her, seductive, and euphoric. Nursing staff tell you that she hasn't slept in at least 2 days. What is the most likely diagnosis in this case? This is a case of substance medication-induced bipolar disorder, the essential feature of which is a hypomanic, major depressive, or manic episode that's linked to exposure to a substance, medication, or toxin, but that doesn't include hypomanic or manic episodes that occur after substance, medication, or toxin has been withdrawn or persists beyond the physiological effects of the substance. The DSM-5-TR criteria can be abbreviated to read: a mood disturbance, elevated, expansive, irritable, depressed, anhedonic, or irritable in kiddos, with evidence of connection to withdrawal or intoxication with a substance or medication that can cause those symptoms. It's not due to another bipolar-related disorder, and is not just delirium. It must result in functional impairment. There are 2 specifiers in this case. They are with onset during intoxication and with onset during withdrawal. These are common substances associated with a substance or medication-induced bipolar disorder. You notify the neurology team of your presumed diagnosis. Interested, the neurology resident asks you to comment on the epidemiology and risk factors for this condition. How would you respond to the neurology resident? It's kind of a trick question. So these answers will do little to satisfy our inherent need to know stuff. In terms of epidemiology, there's limited epidemiological data regarding the prevalence of substance or medication-induced bipolar-related disorder. It likely depends on the country under study and the substances available to that society. In terms of risk factors, it's likely the same as those for substance use, or it would include medical conditions which require treatments that may trigger bipolar disorders. Sounds like maybe you don't know what you're talking about, seeing as you don't know the epidemiology and risk factors for substance medication-induced bipolar disorder. Can you at least tell me what the differential diagnosis is for this condition? What is the differential diagnosis for substance medication-induced bipolar disorder? Instead of a lengthy differential diagnosis for substance and medication-induced bipolar disorder, DSM-5-TR offers us this pair of statements. Concerning hypomanic and manic episodes, it's important to remember a fully symptomatic manic episode that emerges during antidepressant treatment, such as with medication or ECT, but persists at a fully syndromal level beyond the physiological effect of that treatment is sufficient evidence for a bipolar I diagnosis. And fully symptomatic hypomanic episode that emerges during antidepressant treatment, such as with the medication or ECT, but persists at a fully syndromal level beyond the physiological effect of the treatment, is sufficient evidence for bipolar II diagnosis only if preceded by a major depressive episode. And in terms of substance intoxication and withdrawal, remember that euphoria, irritability, increased energy may occur in intoxication or withdrawal, and usually substance-specific intoxication or withdrawal will suffice as a diagnosis. And a diagnosis of substance intoxication or substance withdrawal is made when the euphoric or irritable mood or increased energy symptoms are predominant in the clinical picture and are sufficiently severe to warrant clinical attention. Well, at least you know the differential for this condition. It's kind of short, though, don't you think? How are you going to treat her? She needs the steroids. Safety in mind, how would you approach treatment in the case of substance medication-induced bipolar disorder in general? Well, regarding treatment of substance medication-induced bipolar disorder, the disorder should resolve following cessation of the inciting irritant. But also, keep in mind that if the patient is depressed secondary to a substance medication, you can generally use antidepressants safely. And in the event of manic symptoms, you can consider second-generation antipsychotics. According to my research, quetiapine and olanzapine have the best evidence, and I'll link the article in the notes below. Now on to case 5. You're a PGY1 resident currently rotating through neurology, and you've been asked to see a new consult. Wendy is a 24-year-old female with a chief concern of blurry vision and disruption of horizontal conjugate ocular movements on exam. Start to complete your exam as she is speaking rapidly and exhibits tangential thought form. Collateral history from Wendy's sister Linda is significant for a recent change to irritable mood and increased goal-directed activity. What is the most likely diagnosis in this case? This is bipolar disorder due to another medical condition, the essential feature of which is prominent and persistent period of abnormally elevated, expansive, or irritable mood and abnormally increased activity or energy. Criteria can be abbreviated as meeting the essential feature, evidence that the mood change is associated with a general medical condition, can't be due to another mental disorder, it can't occur solely in the context of delirium, and it must cause dysfunction. Specifiers pertain to which type of mood episode is present, and there are a number of medical conditions associated with the onset of manic symptoms. Wendy is admitted to the neurology ward, and consultant liaison psychiatry is asked to follow her throughout admission to ensure resolution of her symptoms. The next day, you run into Linda, Wendy's sister, on the ward, and she poses a series of questions related to the diagnosis of bipolar disorder due to another medical condition. Specifically, what is the lifetime prevalence of bipolar disorder due to another medical condition, and what are the risk factors? Like substance and medication-induced bipolar disorder, the epidemiology aren't very satisfying here. There are no epidemiological studies on the incidence or prevalence of bipolar disorder due to another medical condition. Frequency and gender prevalence depends on the underlying medical condition, for example, lupus being more common in females and stroke more common in older males. For risk factors, having a medical condition that can lead to the development of manic symptoms and consequently risk factors for those medical conditions, such as Cushing's and MS. In terms of prognosis, it's pretty good as long as you treat it appropriately. Symptoms may resolve before or just after the medical condition is resolved, particularly if the treatment of the mania or hypomania is effective. Linda is reassured with your knowledge of bipolar disorder due to another medical condition, but goes on to ask you, "Doctor, could anything else be going on with my sister? What is the differential diagnosis for bipolar disorder due to another medical condition?" At least this one's kind of short. Here's the differential diagnosis for bipolar disorder due to another medical condition. Let's explore how these differ. So how does bipolar disorder due to another medical condition differ from delirium and neurocognitive disorders, and can it coexist? Well, a separate diagnosis of bipolar and related disorder due to another medical condition is not given if the mood disturbance occurs exclusively during the course of a delirium. However, a diagnosis of bipolar and related disorder due to another medical condition may be given in addition to a diagnosis of major or mild neurocognitive disorder if the mood disturbance is judged to be a physiological consequence of the pathological process causing the neurocognitive disorder, and if symptoms of irritability or elevated mood are a prominent part of the clinical picture. What about catatonia, which General medical conditions are a common cause of catatonia. And what about acute anxiety? Well, DSM-5-TR is very helpful here. It's important to differentiate symptoms of mania from excited catatonic symptoms from agitation related to acute anxiety states. So I think it's a little more helpful to think about the physical signs we might see in catatonia and to think about the transient nature of anxiety. What about medication-induced depressive or manic symptoms? How can we tell the difference? Well, again, DSM is super helpful here, so here's what they say on the topic. An important differential diagnostic observation is that the other medical condition may be treated with medications, that is steroids or interferon alpha, etc., that can cause or induce depressive or manic symptoms. In these cases, clinical judgment using all the evidence in hand is the best way to try to separate the most likely and or the most important of the two etiological concerns. That is, association with the medical condition versus a substance or medication-induced syndrome. Differential diagnosis of the associated medical conditions is relevant, but largely beyond the scope of the present manual. Linda continues, the neurology team tells you that they have some treatment for my sister and her condition. Is there anything we can do from a mental health perspective to help settle her down? Safety in mind, how would you approach treatment in the case of bipolar disorder due to another medical condition? Treatment should be guided by the treatment of the underlying medical condition. Of course, should the need arise for treatment of agitation or aggression, etc., then the use of standard assortment of pharmacological agents indicated for those problems, such as Haldol, might be appropriate. Unlike delirium, we might be able to get away with a benzo. I'm not sure if I'd risk it, though. Well, we're getting closer to the end now. I can feel it. Let's consider these twin cases side by side. It's a busy night on call, and you've just received 2 consults only seconds apart for patients presenting manic. Case of Matthew. This patient presents with elevated mood and increased goal-directed activity along with rapid speech. They are aggressive and the interactions last only a few minutes before he must flee the room due to escalating aggression. Case of David. This patient presents with irritable mood and increased goal-directed activity, reports not needing sleep for the past 2 days. He has missed work as a result of this. What are your diagnoses in these cases? So Matthew has other specified bipolar-related disorder, which is characterized by symptoms of bipolar disorder leading to dysfunction, but the individual doesn't meet criteria for any bipolar-related disorder. In others specified, the clinician chooses to say why they don't meet the criteria. One example of this would be a short-duration cyclothymia. David, on the other hand, has unspecified bipolar-related disorder. This disorder is characterized by symptoms of a bipolar-related disorder that leads to dysfunction, and again, it doesn't meet criteria for any bipolar-related disorder. In these cases, the clinician chooses not to say why, and this might be appropriate in the emergency department, where more information is not available. Okay, this is the last one, I promise. Case 8. Uno presents to your family medicine clinic because he has been sad for the past 2 days. On exam, he speaks so fast he can hardly perceive the words coming out of his mouth. He barely managed to learn that he lost his job yesterday due to his behavior at work. When he suddenly stops talking and runs out of your office with tears streaming from his eyes. What is the most likely diagnosis in this case? This is the catch-all diagnosis of unspecified mood disorder. This category applies to presentations in which symptoms characteristic of a mood disorder are present that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, but does not at the time of the evaluation meet full criteria for any of the disorders in either the bipolar or the depressive disorders diagnostic classes, and in which it is difficult to choose between unspecified bipolar and related disorder and unspecified depressive disorder, such as in acute aggression. This is a summary of all the things that we talked about today, as well as their key features. Thanks for your attention, everybody. Please have a great weekend.